Today I'm describing the neurological blueprint of examinations. First pictures is proximal muscle weakness test. Um, if a person seated for the long time, he may affected the proximal muscles and didn't stand due to proximal muscle weakness. There is some pathological cause for proximal muscle weakness. Examples is hypothyroidism or hyperthyroidism, Cushing syndrome, inflammatory and pathological is dermatomyositis, polymyositis, etc. Here is the pictures of a person having the proximal myopathy. Identifying the fascinating gait. Fascinating gait is found in case of Parkinson disease where the basal ganglia lesions, dopamine deficiency. So posture is forward, stooped, aligned, and initiations of walking, freezing or hesitation before first step is called the fascinating gait. Descriptions of the fascinating gait is posture, forward and stoop, and initiations is difficult, freezing and hesitation before first step, and very small step that progresses increasing the speed and changing their own center of gravity. Record the wild multiple arch of round, and associated scientists reduce arm swing and also pin rolling tremor or resting tremor is present in case of Parkinson disease. So in gist we found the fascinating gait. What is the fascinating gait? That is patient stoop forward and difficulty to initiation of walking, that is freezing and hesitation before first step, and step are small, and also there is a reduced arm swing, resting tremor, pin rolling movement. Lesion is the basal ganglia dopamine deficiency pathway. Differentiating the ataxia, the lumbar pivot side. We have two types of the ataxia, that is the cerebellar ataxia and another is the sensory ataxia. How can we differentiate two? In case of sensory ataxia, we do the lumbar sign. Lumbar sign is that if a person stand and eye close, if there is a vitamin B12 deficiency, then patient may fall and is called the positive lumbar side. And in case of cerebellar ataxia, patient can walk, that is drunken gait, a vaulting wide-based step and swing right and left, and patient fall towards the same side as the cerebral lesion. Patient may swing or fall even with the eye open, and in case of sensory, eye is closed and patient fall. In case of eye open, patient didn't fall. It's due to vitamin B12 deficiency or dorsal column lesions. Then spastic and neuropathic motor deficit. Spastic gait means seizure gait, driven by severe adductor muscles overactivity, leg crosses over each other during walking, and often seen in the upper motor neuron lesion. Neuropathic high stepping gait, driven by foot drop. The patient must artificially lift the knee high to prevent the dragging the toes on the ground. hemiplegic arch circumduction. Unilateral weakness prevents normal knee flexions and hip clearings. To move the affected leg forward, the patient must swing it towards the rigid and semi-circular arch. The circumduction pattern is the hallmark of the unilateral stroke. Accompanying sign often accompanied by the several steps, circumductions, arm on the same side of the body help the rigid against the torso. Stroke recovery profile, ischemia versus hemorrhagic. Um, in case of hemorrhagic compression, blood pooling compresses the nerve but does not completely destroy them. So once blood is absorbed, nerve return to the back position. So hemorrhage is highly lethal early, allow the dramatic functional recovery in case of patient survive. But in case of ischemic stroke, lack of blood supply that permanently damaged the neural tissue, and maximum functional recovery is usually kept 20 to 30%, and leaving the severe residual weakness and ischemic causes long-term suffering. So hemorrhagic stroke, in case of hemorrhagic stroke, there is early recovery because nerve damage is less, because there is does not completely destroy the nerve. But in case of ischemic stroke, due to lack of the blood supply, nerve will be destroyed, and here recovery is late, slow. Cranial nerve, optic nerve pathway, that is here is the two disease that involving the optic nerve. One is the multiple sclerosis. Multiple sclerosis that causes the optic neuritis. Optic neuritis means sudden painful vision loss, color vision loss. We can examine the color visions by the Ishihara chart. This is the macroadenoma. Macroadenoma is that compressions of the optic chiasma. Optic chiasma. There is in above the optic chiasma, if there is any tumor, it's called the craniopharyngioma, and below the optic chiasma, if there is arises any tumor, is called the macroadenoma. So any compressions above or below, there is a bitemporal hemianopia or tunnel visions. If there is compressions below the optic chiasma, that is the macroadenoma, that losses the superior part, and if there is a craniopharyngioma from above to downward, is the inferior inferior vision loss. We can testing this by the Snellen or distance chart or confrontations field testing. Pituitary tumor compresses the optic chiasma from below. Third cranial nerve is very important. It is the parasympathetic nerve, and it supplies the levator palpable superior muscles in the eye, and if it is cut, then ptosis may present, complete ptosis may present, and if it is parasympathetic, so if cutting off the parasympathetic fibers, the eye may be the mydriasis or dilated pupils, and eye turn to the down and outward, and also there is a converging squint because the medial rectus is supplied by the oculomotor nerve. So if there is any damage to the oculomotor nerve, I cannot move medially. So here is a convergent squint are present, and complete ptosis described before. So third nerve also we found the ptosis, mydriasis, and also eye down and outward and convergent squint. pupils, we found the ischemic compressions and aneurysm compressions. Diabetic neuropathy damaged the internal nerve fibers of the um, third cranial nerve, that is oculomotor nerve. So in case of damage due to the diabetic neuropathy, the pupil may spared. Pupil size is normal and reacting to the light. But if there is a aneurysm due to the external compressions, the outer part of the um, oculomotor nerve will be destroyed and pupil may be dilated and also unreactive, because oculomotor nerve is the parasympathetic nerve. Bulbar palsy and pseudobulbar palsy. Bulbar palsy means the lesion in the brain stems, means the lower motor neuron type lesions. So if there is a lesions in the brain stem, we call it the bulbar palsy. And here is the swallowing difficulty due to damage of the vagus nerve. There is a bovine cough present, nasal voice present, swallowing difficulty present, speech difficulty present, hoarseness of the voice, nasal voice will be present. And bulbar and pseudo, difference between the bulbar and pseudobulbar. Here is the we can see the location of the bulbar palsy and pseudobulbar palsy. Bulbar palsy means lesion in the brain stems, and pseudobulbar above the brain stem. Bulbar palsy is the lower motor neuron type palsy. So here is the tongue fasciculation, wasting present, flaccid tongue will be present, and reflexes absent or diminished. In case of pseudobulbar palsy, it's called the upper motor neuron type of the lesions. So here is no muscle wasting in the tongue, or there is present the stiffness, spasticity, and reflexes are exaggerated, that is jaw jerk will be exaggerated. We can see the two pictures, that is the pre-centered gyrus and post-centered gyrus. Pre-centered gyrus, that is responsible that is called the motor cortex, that is responsible for the motor activity in the body. It's also called the primary motor area. And in post-centered gyrus, this is called the sensory cortex. This is called primary sensory area. So this is called the motor homunculus. The medial part and lateral part. There is a medial part and lateral part. Medial part of motor cortex is supplied by the anterior cerebral artery, which is responsible for the leg weakness and other mild arm weakness. But in case of the MCA, middle cerebral artery, which is responsible for the hand weakness and others thumbs weakness. So the more neuron is present in case of medial side of motor area, and is supplied by the anterior cerebral artery, and lateral side is supplied by the MCA, medial cerebral artery, which is responsible for the arm and thumb. Is the difference, that is